just going to share what I have learned over the past few years. So, I'm going to speak on anesthesia for pituitary surgeries. First of all, any surgery I feel is a teamwork, more so in this case because there are more team members. So, it actually starts from the endocrinologist, usually, who identifies a patient, sends to a neurosurgeon, goes to a radiologist, and then gets diagnosed. Then we come into picture. And finally, we have the ENT surgeon also who helps to gain access to the tumor. Though each one of us has an individual specific role to play, I think involving and investing ourselves in each other's role helps us understand the pathology better, and that helps in the intraoperative and perioperative management. So we are going to stick to mostly the transsphenoidal endonasal approach, which is the most common approach nowadays, except for extremely large tumors with a very large suprasellar component, wherein the transcranial approach is utilized. So the preoperative concerns. So basically, we all have to understand that it's an elective surgery most of the times. So we have ample amount of time to do all the investigations and do some preoperative optimization as well, so that we have a very smooth and a good perioperative outcome. So mainly we are concerned about, now the pituitary secretes a lot of hormones. So we need to know the hormone hypersecretion effects, or there are some hyposecretion effects, or there are, because of the sheer mass of the tumor, there are some pressure effects. So these are the preoperative symptoms that the patient comes with. So a little bit about the physiology. There is an anterior pituitary and a posterior pituitary. The anterior pituitary secretes hormones called TSH, ACTH, prolactin, growth hormone, and FSHLH. The posterior pituitary secretes oxytocin and ADH. So of more importance to us is the growth hormone, excess of which causes acromegaly, and ACTH, excess of which causes Cushing's. So what are the different pathologies that the patient can come with? They can have a macroadenoma or a microadenoma. They can either be a hormone secreting tumor or just a non-functional tumor. Now, hormone secreting, as I said, can cause acromegaly, excess of growth hormone, or Cushing's, that is excess of ACTH. There can also be a TSH secreting tumors. These are mostly managed conservatively with medications. There can also be prolactin secreting microadenomas. Now, one small thing about this is these patients are on cabergoline or bromocriptine. Now, these drugs are known to cause orthostatic hypotension, so we need to be a little more cautious intraoperatively. Or posterior pituitary tumors can present with diabetes insipidus or SIADH, wherein there can be electrolyte abnormalities which need to be corrected and pre-optimized in the preoperative period. So we all know the most commonly is the acromegaly. So they have very typical facial features, and the most easy way to identify is they actually resemble Shrek, who's the cartoon character which is taken from a wrestler who had acromegaly. So it is excess of growth hormone. As we all know, there is macrognathia, there is macroglossia, there is more important for us, there is hypertrophy of the epiglottis. So the Malampatti grading is unreliable. They might have a very big mouth opening, but once you put in the scope, they have a huge epiglottis, making intubation difficult. But usually they can be managed with a videolaryngoscope and a bougie, but a fiber optic bronchoscope should be kept ready in case required. More important, I feel, is the difficult extubation of these patients, because a lot of them, more than 50% of them, have obstructive sleep apnea. So that causes difficult extubation. They mostly require postoperative BiPAP, which in this case we cannot give because there is a bony defect. So the nasal cavity is directly connected to the brain because the sphenoid bone is drilled, and later it is only covered with a fat graft. So there is still a bony defect. So postoperative BiPAP is not an option. So we need these patients to be completely awake during extubation. They are also present with hypertension and LVH, and that has to be treated. At least the hypertension can be controlled. Nerve entrapment syndromes. Now, these patients usually have soft tissue enlargement, which is everywhere. So there can be nerve entrapment, which has perioperative implications, as in we need to be very careful about the positioning of these patients. The second is Cushing's, which is excess of ACTH. We all know that Cushing's presents also have obesity and a difficult airway, hyperglycemia, hypertension. They also have proximal myopathy, which makes extubation again difficult because it can cause post-operative pulmonary complications. Again, the importance of an extremely awake extubation. They also have fragile skin and they are more prone to venous thromboembolism. So the correctable things in this can be either hyperglycemia and hypertension can be corrected, and preventable things are that we can prevent thromboembolism with at least pneumatic pump. Now, the third one is the pressure effects. Now, sometimes the pituitary is a non-functioning tumor, but because of the sheer size of it, it can cause pressure effects. For this, we need to know a little bit about the anatomy, so that what are the structures surrounding it. So as you can see here, the pituitary gland is placed in the sella turcica. Now, this on lateral, both the lateral side, there are the internal carotids and the cavernous sinuses. Above is the roof, which is formed by the diaphragm sellae, plus there is the optic chiasma and the third ventricle, and that is why there, and on both the lateral side there are the cranial nerves 3, 4, 5 and 6. So these patients can present with visual field defects. So most of them have undergone a perimetry done. What is important for us is the preoperative pupillary reflex. If we just see, now these patients sometimes have bitemporal hemianopia. So if you project the light from the nasal side, they might not show a pupillary reflex. So it's important for us to know this so that in the postoperative period, we can avoid any kind of chaos. Cranial nerve palsies are common, panhypopituitarism, and they can also present as hydrocephalus due to blockage of the third ventricle. Now, the investigations, as I said, according to all the routine baseline blood workup has to be done, including hormone levels, which are usually done by the endocrinologist. ECG and 2D echo is also must. The 8 a.m. cortisol and the synactin test will come to a little later. So I feel we need to prepare ourselves and we need to prepare our patients also for this surgery. So the important thing is the perioperative glucocorticoid. Now we all know about the hypothalamo-pituitary adrenal axis or the HPA axis, which might be affected in these patients. So we need to do, ideally, the evaluation of the HPA axis is done by the endocrinologist. So what they do is they do a 8 a.m. cortisol test, which helps us to know the baseline value of the cortisol. But it is important to also know the synactin stimulated cortisol test. So we know how will the cortisol be in the times of stress. So if both of these tests are normal, that means the HPA axis is normal, and all we have to do is at the time of induction give 1 dose of hydrocortisone. But if any of these tests are affected and the HPA axis is affected, this is the regimen that we follow: 100 mg hydrocortisone at induction, followed by 4 mg per hour hydrocortisone for the next 24 hours. Then it is tapered off over the next 3 days and then followed by oral steroid. So this mimics the metabolic requirement or the baseline cortisol secretion, and that is why we follow this regimen. But in case the 8 a.m. cortisol and the synactin test is normal, then the only thing we need to do is give at induction a 100 mg hydrocortisone dose. Now, the nasal mucosa preparation, I think these are small things but go a long way in making our intraoperative job easy. So the nasal mucosa preparation starts 3 days prior. So 3 days prior to the surgery, the patient is on antihistaminics. The patient is on nasal drops, so xylometazoline drops 3 days for 3 times a day for 3 days. So this helps that on table when the patient arrives, the nasal mucosa is already prepared. So all the ENT surgeon needs to do is put a nasal patty with lignoadrenaline. So this infiltration of adrenaline is avoided, so that rise in BP, which happens when the ENT surgeon infiltrates adrenaline, is avoided, and plain saline infiltration for hydrodissection also works. Now, intraoperative, now once the patient is ready for surgery, the patient has to be counseled about the fact that it is good that the nasal mucosa, the nasal packing will be done, and he has to be preoperatively counseled regarding mouth breathing in the postoperative period. So counseling regarding the postoperative nasal packing. Now, when difficult airway is anticipated in case of obesity or acromegaly, it is better to avoid sedative pre-medication, but routine pre-medication in the form of glycopyrrolate, pantoprazole, MCET, tranexamic acid, and steroid is to be given. So steroid cover we have already seen. Nasal mucosa preparation we have already seen. Now we take an arterial line for most of our patients. If arterial line is to be taken in the radial artery, it is very important to do the Allen's test, because these patients have soft tissue edema, carpal tunnel syndrome in case of acromegaly. So what happens is the ulnar artery is already compressed. And if you take the radial artery, it can actually lead to ischemia. So it is important to do the Allen's test. We all know, I'm just going to revise a little bit, that a radial artery and ulnar artery both are occluded, which causes blanching of the palm. And then the ulnar artery is released to see whether the ulnar artery has flow. So once this is confirmed, you are free to take the radial artery. If not, it is better to take the dorsalis pedis, which is also easy and approachable. So we take an arterial line for most of our patients. A urinary catheter is compulsory for all patients, more so intraoperatively, but more so postoperatively, because within 24 hours, there is a chance that they might go into diabetes insipidus. And then measuring the urine output becomes utmost important. Head up position is usually given for most of the patients to reduce bleeding. But one thing I would really like to add here is this is not a ENT surgery, it is a neurosurgery. So the hypotension which we usually think of for ENT surgery is not advised here, because we need to maintain the cerebral perfusion pressure. Plus there is a head up position. So it is very important to give normotension. Blood loss is expected and can be sudden, because there is, as you saw in the anatomy, there is cavernous sinus very close, there is internal carotid artery very close. So there can be massive blood loss, and blood should be cross matched and kept ready. Now, a very important thing is the lumbar drain. So for most of our patients, we put in a lumbar drain, which is an epidural catheter which is placed into the subarachnoid space. So after induction, after the radial artery is cannulated, we put the patient in the lateral position and put in an epidural catheter into the subarachnoid space under strict asepsis. It is immediately not drained, it is kept closed. Once the surgeon reaches the initial resection of the tumor is done, what we do is the lumbar drain is allowed to drain some CSF. Now, this reduces the intracranial pressure and the bulging arachnoid relaxes, and it actually helps to improve the exposure, and the remnant tumor can be removed. So we have seen that this really helps intraoperatively. Now, this lumbar drain is kept for the next 48 hours in the post-operative period, because in case there is any CSF leak, then this lumbar drain is just opened, and that CSF leak usually stops and heals by itself. So it has two roles to play. Now, as I said, so what happens is this is the tumor, and once the lumbar drain is opened, this relaxes. So what a lot of other institutes, what they do is put in air or saline, they push through the lumbar drain for the ICP to rise so that the remaining tumor comes down. But what we have seen is, instead of tumor completely coming down, what happens is it causes tumor remains in these crevices. So it is better to actually drain CSF. And this is a small video which is showing how the once the lumbar drain is opened, how the it relaxes the brain and how the remnant tumor can be easily removed. So just going to play the video. Yes. So after the initial tumor is removed, what we did is lumbar drain was opened. So the tense bulging arachnoid has relaxed, the exposure has improved, and a lot of tumor which was still remnant and not seen before is now seen and can be removed. So the tumor which lies hidden behind the diaphragm waist is also removed after opening the lumbar drain. So another important thing I feel is, for any surgery, it is important to know what are the major surgical stimulus, or where exactly is the painful stimulus going to be and when during the surgery. So I think in this surgery, the initial nasal mucosa preparation, when the ENT surgeon instills, sometimes they do have to instill adrenaline infiltration. That is when the BP rises, and that can be difficult to manage. Second is the nasal septum fracture. So what they do to improve the exposure and improve the visibility, they actually fracture the nasal septum, and that is a major surgical stimulus. We need good analgesia at that time. Breach of the sphenoid for access into the fossa. So before entering, they have to breach the sphenoid for the access, and that is a major surgical stimulus. The rest of the surgical procedure is fairly painless. So once they reach the tumor, we can actually go down on our analgesia, and so that, because at the end of the surgery, we want an awake and a completely reversed patient, I think it is important that we titrate our analgesia and inhalational agents accordingly, because beyond this, rest of the surgical procedure is fairly painless. I think it's also very important to pre-plan the ergonomics of the OT for those who or all of us who, we are not doing pituitary surgeries every day. So on the day of surgery, pre-operative preparation of the OT is also, I think, very important, because as you can see, there is an ENT surgeon and a neurosurgeon right at the head end, and so then there are monitors, and where we are is actually at the complete foot end of the patient. So it's very important to, for these small things like putting the tube and then fixing it on the left side, taking a left radial artery, having long tubings, all of this help in avoiding any kind of intraoperative mishap and chaos. As I already said, that there is a known difficult airway. We need to keep all our video laryngoscope and fiber optic bronchoscope ready. More importantly, I feel, because they have a overhanging long epiglottis, it is a longer laryngoscopy blade, which has usually helped me. Apneic oxygenation definitely helps to give us some more time. Flexometallic tube is what is used. As I said, is fixed on the left side because the surgeon stands on the right side. A throat pack is inserted, one, yes, for the secretions and the bleeding which occurs, but also for fire safety, because they are using cautery very closely, and that is why the throat packing is important. Now, emergence and extubation, I have been saying that we need an awake patient, but we also need a smooth in extubation. So I think these two things usually don't go together. Anything that is rapid cannot be smooth, but we need to achieve it, and it's possible. So what we need to do is remove the throat pack. The nose is packed. We need to avoid coughing. We need to avoid positive pressure, mask ventilation after extubation, and we definitely need to avoid post-operative BiPAP. So all of this is possible, and now more so because of Sugammadex. So the reversal that we get with Sugammadex, I think, is a complete reversal, which definitely helps in these patients. And as I said, we need to titrate the inhalation agents better during the end of the surgery, so that by the end of the surgery we have a completely awake and completely reversed patient. As I already mentioned, the pupils, if you check, we need to be very sure of the preoperative bitemporal hemianopia if it was present. If the surgeon wants to do the neurological assessment immediately, they need to check the cranial nerves, they need to check the responses, and that is why we need to have an awake and a completely reversed patient. Now, a little bit about the post-operative complications. First of all of these patients go in the ICU. A lot of times these patients are completely awake. There is no craniotomy, there is no incision as such, and the patients look very, very fine and can be shifted to the ward. But we need to know that it is a neurosurgery, and all of these patients should be monitored in the intensive care unit for at least 24 to 48 hours, because after 24 hours, they usually go into diabetes insipidus, which then requires serial measurements of sodium and the urine output for adequate management. It usually goes on for 7 days and can be managed with desmopressin. Now, another important thing in acromegaly is that once the complete removal of the tumor is done, they sometimes go into diuresis, because there is a lot of water retention preoperatively, and suddenly, after the tumor is removed, they go into diuresis. Now, this has to be differentiated from the diabetes insipidus, and that is why it is important that we know the intraoperative fluid that we are giving has to be absolutely monitored and mentioned, so that the post-operative diuresis can be assessed. There can be a CSF leak. Now, as I said, because we have a lumbar drain in place, we can just open the lumbar drain and usually this CSF leak stops and heals on itself. The post-operative apoplexy from residual tumor, very rare. And again, in this, a smooth extubation goes a long way. Panhypopituitarism, and then they require hormonal replacement. A very rare complication which occurred just once is that post-operatively, this patient had a lot of sneezing and retching, and the fat graft which was put on the sphenoid actually herniated into the brain, and we had to go for a craniotomy. It's a very rare complication. One important thing is now this bony defect which is there is just covered with a fat graft and nasal packing is done, and this defect remains almost for 2 weeks post-operatively. So any nasal intubation or a nasogastric tube is completely contraindicated because it can directly go into the brain at least for 14 days post-operatively. We do not have to do any intervention in the nasal cavity. So I just need to sum it up by saying that we all know the story of this blind men and elephant, wherein all of them have their own perspective. But I think it's now important for us to see the entire elephant. There is so much to learn from all of these neurosurgeons and endocrinologists. And if we all come together and look at the whole picture, I think it will definitely help to give a better perioperative outcome. Thank you so much. Thank you.